Thank you for inviting me to speak about intestinal emergencies and vascular Ehlers-Danlos syndrome. My name is Jessica Zagory, and I'm a pediatric surgeon at Louisiana State University Health Sciences Center and Children's Hospital of New Orleans. I have no disclosures. Today, I will discuss the types of intestinal emergencies and vascular EDS, the operative management pearls and pitfalls, and long-term gastrointestinal outcomes. Hollow viscous perforations are also very common, but not what many people typically think of as a hallmark of vEDS. In fact, 25% of vEDS patients suffer from intestinal perforation during their lifetime, and for many, this is the first presentation of this disease. With patient and parental permission, I'm going to share a case today of a patient I'm currently taking care of. She is a 16-year-old girl who was transferred to our emergency department with 2 days of intense abdominal pain and a CT scan concerning for rectal narrowing. Of note, she had cleft palate repair as a baby and has been seeing one of our orthopedic surgeons for recurrent hip dislocations. She was also told she had irritable bowel syndrome for 2 years, intermittent crampy abdominal pain without any obvious underlying cause. On exam, she appeared very sick, with a high heart rate and diffuse peritonitis. When I reviewed the CT scan from the outlying institution, there was dilated sigmoid with an acute transition point in the rectum, seen here with the arrow. Given that she was in distress, we repeated an upright X-ray, and sure enough, she had pneumoperitoneum, or air that shouldn't be outside of the bowel, signifying that sometime between her CT scan and arriving at our hospital, she had perforated her bowel. We did an emergency exploratory laparotomy right away and found that her sigmoid had a large perforation. We performed a sigmoid resection and created an end colostomy. This is a great representative photo that I found by Yoneda and colleagues, which shows the perforation in the very thin sigmoid that looked exactly like our intraoperative findings. Additionally, the mesentery was incredibly friable and with the consistency of tissue paper. Any tension on the tissues tore these vessels. As in their pathology specimen, we again saw necrosis in the thinned out sigmoid colon of our specimen. And on the microscopic images, there's irregularity and segmental absence in the muscularis layer of the sigmoid. Our patient was also found to have segmental absence of intestinal musculature. Our patient's postoperative course was complicated by wound dehiscence, as you can see here, as well as pneumonia. Because of the delicateness of her tissues, we had a high suspicion for connective tissue disorder and consulted genetics. An echocardiogram showed that she had a mildly dilated aortic root. And finally, her genetic testing confirmed that she did have a collagen defect consistent with vascular EDS. As we will see in the literature review to follow, the most common intestinal emergency in vEDS patients is colon perforation, and 80% of these is in the sigmoid colon. Evaluation of the histology shows that in the majority of cases, this is due to an abnormality in the muscularis layer. For many patients, this is the first presentation of the syndrome, and the marked difference in the tissues during the operation should alert the surgeon of an underlying connective tissue disorder. Because intestinal perforations are always an emergency, the bowel is never prepped, and the patient is often in extremis. For that reason, the safest operation is an end colostomy and resection of the perforated segment. vEDS is rare, and thus what we know about the intestinal manifestations come from review papers and meta-analyses. Frank and colleagues in Paris reviewed their 17-year data. Gastrointestinal events were the index case in 80% of their vEDS patients. In patients with multiple GI events, the mean age at genetic diagnosis was significantly younger than those with fewer events. Colonic perforations and multiple perforations are the most common GI manifestation. Other abdominal or gastrointestinal events in vEDS patients includes intestinal pseudoobstruction, which our patient had, splenic rupture, GI bleed, diverticulitis, and small intestinal perforation. When looking at the characteristics of patients with colonic perforation in their cohort versus those who did not have colonic perforation, patients with colonic perforation had a significantly higher number of gastrointestinal events, were on average 10 years younger at genetic diagnosis and at first GI event. So, once you've managed their emergent intestinal perforation, what are the considerations for the future? It is important to counsel these patients on the risks of additional intestinal perforation. Family counseling and genetic testing must also be done. And in our case, the 16-year-old who wants to go to the beach vacation with a two-piece and go to college without a colostomy, what are her next steps? Speak et al. Recently published a systematic review on the management of colonic perforations in vEDS patients, which I found to be incredibly useful. In their review, they found that patients who initially underwent an emergent exploration for perforation had a series of different operations, from a Hartmann end colostomy, total abdominal colectomy with ileorectal anastomosis or with end ileostomy, reanastomosis, among many other different operations. What was striking to me about this is that even though we consider an end colostomy to be a very safe operation in general, in this particular population of vEDS patients, the risk of reperforation is still significant. When followed long-term, patients who still had colon in situ had a significantly higher incidence of visceral reperforation, and for this reason, the authors suggest total abdominal colectomy with either an ileorectal anastomosis or a permanent end ileostomy. Patients should also be counseled that despite gentle handling of tissues in extreme care, the ileorectal anastomosis carries a 20 to 30% risk of leak. Our patient elected for a total abdominal colectomy and ileorectal anastomosis. My takeaways for intestinal emergencies in vEDS and suspected vEDS patients is that the first presentation is most often an emergency, and thus time is of the essence. Obtain expedient cross-sectional imaging, which also allows for evaluation of the abdominal vasculature. At the initial operation, as well as subsequent operations, if any, consider a permanent colostomy or ileostomy. Discuss with the patient and family that there is a 50% chance of a second colonic perforation if colon is left in situ. For abdominal closure and anastomoses, tissues must be handled gently and be tension-free at completion. And as we discussed, there is a high leak rate postoperatively, and the surgeon must maintain a high index of suspicion. Due to the collagen defect that affects blood vessels, I have found that IV access can be a struggle for these patients. If you have the opportunity to place a peripherally inserted central venous catheter or other stable access to minimize the placement of peripheral IVs during their hospital stay, I highly suggest it. Maintenance fluids or bolus resuscitation can blow even a large gauge IV. Nasogastric tubes should be placed gently, and care must be taken if one is to perform endoscopy. In fact, many in the literature recommend against invasive testing or procedures unless absolutely necessary. Likewise, when it came time to perform a reversal for a patient, I performed the contrast enema myself in the operating room to ensure that minimal pressure was applied and that we would be ready in the event of an iatrogenic perforation. And finally, if you work at an institution that does not have a multidisciplinary connective tissue disorder team, I cannot stress enough the importance of referring to an institution that has an experienced team. I have learned so much from sending my patient to these centers about the comprehensive, long-term care that these patients need, from imaging evaluation and follow-up to psychiatry and patient support groups. I thank you for your attention and look forward to your questions at the conclusion of our session.